Patient is a 34-year-old male who presents to the ED for evaluation of hypertension and elevated heart rate. Patient has a history of hypertension for 3 years and was previously on blood pressure medications. He was taking 2 medications previously, but cannot recall the names. He states that he was taking them for a little over 1 year, but had no improvement of his blood pressure. He was previously seeing a doctor in Connecticut, where he used to live, and he moved to New Jersey about 1 year ago. He was taken off of the blood pressure medications in December 2019 because they were not working. He states that over the past few months, he has felt some chest pressure and intermittent upper back pain, occasionally associated with shortness of breath on exertion that has been worsening over the past week. However, he does note that he plays tennis a few times a week without difficulty, chest pain, or shortness of breath. He followed up with Dr. Rubenstein, cardiologist, in the office yesterday and was noted to be markedly hypertensive. Dr. Rubenstein therefore referred him to the emergency department. However, patient was unable to come yesterday due to childcare and now presents today for evaluation. Otherwise, there are no visual symptoms and there is no focal weakness. This patient's critical care, so make sure you put in the critical care macro. Patient required my immediate medical attention upon arrival to the ED for hypertension and tachycardia. Blood pressure upon arrival is 224/171, and his heart rate is 117 beats per minute. The review of systems is all negative, so you can leave that as is. COVID, there is no prior infection. For past medical history, make sure you document that they have hypertension as above, otherwise negative. Social history is negative. He does not have any current medications that he's taking, and there are no allergies listed for this patient. As far as physical exam, the patient is awake, alert, and in moderate distress. Vital signs: pulse ox is 98% on room air, indicating adequate oxygenation. Blood pressure is 224/117 millimeters of mercury, and heart rate is 117 beats per minute. So for the rest of the exam, just make sure that you put he is tachycardic. Otherwise, he's neurologically intact. No other findings on his exam. For diagnostics, labs you can put as below, urinalysis as below. EKG, sinus tachycardia at 114 beats per minute. There is LVH, left atrial enlargement, and there is no prior EKG for comparison as interpreted by me. Rhythm strip, you can just put sinus tach at 114 beats per minute. No ectopy. And lastly, for diagnostics, put in just cardiac echocardiogram and just put pending next to that. He'll have that when he is admitted. For the ED course, of course, it's a critical care chart, so patient seen immediately on arrival because of high probability of imminent life-threatening deterioration in the patient's condition. When he arrived, blood pressure was taken using both arms, and his blood pressure on the right was 235/151, and on his left arm, it was 227/161. Don't forget units for blood pressure, millimeters of mercury. IV access was established and maintained. Labs were drawn. Patient was initially treated with a normal saline IV fluid bolus. Consult was placed to Dr. Bhatt, Bhatt, cardiologist, on call immediately. Prior records were requested and reviewed in Cerner, but there are no prior visits available for review. Orders were placed. I ordered a urinalysis and an EKG. Dr. Batt, B-H-A-T-T, cardiologist on call, arrived to the ER and is at bedside for evaluation. Dr. Batt performed a bedside ultrasound of the heart and noted mitral valve regurgitation and mild aortic insufficiency. A CT angiogram of the chest was initially ordered, but due to elevated creatinine and a negative lactic acid, we decided not to perform this study as it is contraindicated to give contrast with these lab results. At this time, there is low suspicion for aortic dissection. Case was discussed with Dr. Batt, B-H-A-T-T, who requests admission to the CCU and treatment with IV labetalol. Patient was treated with labetalol 20 milligrams IV and placed on a labetalol drip. Cardiac echocardiogram was ordered at this time. Diagnostics and vital signs were reviewed and discussed with patient. And then you can put the critical care macro that says patient reevaluated and observed at bedside for subsequent response to continuing treatment multiple times, x-rays reviewed, et cetera, et cetera. You can leave that macro there. And underneath, put case discussed with CCU resident who agrees to evaluate patient in the ED. CCU resident evaluated the patient in the ED and accepts patient for admission to the CCU. Case discussed with Dr. Rizvi, R-I-Z-V-I, who accepts patient for admission under their service. Critical care time, you can just put 40 minutes. My clinical impression is hypertensive emergency. And then delete all plan and follow-up up to plan, and you can just put admit to CCU under the service of Dr. Rizvi, R-I-Z-V-I. And you get to put your scribe macro at the bottom.